We start the webinar for the EMRO region. It's going to be a nice, wealthy webinar with information. Thanks for IFMBE, for Tom, for Kaliroy, for Yadin, for everybody in IFMBE to offer us the platform so that we can join and share the lessons learned and all the challenges that we facing COVID-19. I'm going to present a little bit the panelists and myself. I'm HTM certified with over 30 years of experience. I collaborate with IFMBE, WHO, Arab Hospital Federation, and MENA HPF, and a member of the American College of Clinical Engineers. But the important are the panelists. They are so rich with experience. We have Dr. Mohsen George Khalaf. He is a surgeon, he's an MD, he's practicing in Egypt. He has a vast and valuable years of experience in insurance, education, training, quality, patient safety, and health financing. He's also an active member of lots of associations, and he's going to enrich the webinar with his experiences. We have Tazim Bukhari and Danielle Fouez from Pakistan. They are clinical engineers working in Pakistan. They work in several projects with the WHO, Ministry of Health, in private and public sectors, and they're going to share their success stories and experiences in the region. We have Dr. Yassin Abdul Samad. He has a PhD in biomedical engineering. He is working in Saudi Arabia, and he has lots of experience and research, and he's going to share his lessons learned and challenges facing COVID. We have Muhammad Yunus. He has also 7 years of experience in hospital planning, HTM, and mobile services needed for COVID. He worked in India, UAE, Kuwait, and Nepal. We have Bassam Tabshouri, a friend and a colleague. He has more than 35 years of experience in clinical engineering. He is also very rich in knowledge and experience. He worked in Lebanon and at AUB, American University. He is a collaborator with IFMBE and consultant to WHO, World Bank, Ministry of Health, and other international institutions. He is expert in Joint Commission, Magnet, ISO, and other things. Definitely his presentation is going to enrich our information. And finally, but equally important, our friend Hugo Gartner. He works with Médecins Sans Frontières in Yemen, and he is a member of NGOs, Hamatam in France, and IFMBE collaborator. So it's a wonderful combination of expertise ranging from MD to quality to HTM. We as clinical engineers in EMRO region, we shall learn the lessons and the experiences shared by our colleagues. A small introduction, these are the definitions that we should all be aligned with. These are the international definitions. Please refer to them later on, because it's very important that everybody talk the same language. These are the definitions of clinical engineers and health technology. IFMBE has worked a lot with WHO, and we in IFMBE, we are promoting the leadership principles, and these are the leadership that lots of webinars are done so that we promote, and we understand that clinical engineers have to be leaders in their countries and in their institutions where they work, and they can make a very big difference. That is a very important information that the opinion shared here, it reflects the persons themselves, and it's an open disclaimer and conflict of interest presentation information in these presentations. Please log into the website of the IFMBE. There are lots of previous webinars done, lots of courses and lots of resources. They are all free, and they all promote clinical engineering, increase your information, and improve you in your career path. So please log in, be active, and we in IFMBE so proud to share all of these information to everybody. Now I proudly present Dr. Mohsen George Khalaf. He's going to present his experience facing related to the COVID-19 pandemic through his practice in Egypt and in the area. Please, Dr. Mohsen, the floor is yours.
Hello, thank you, Dr. Riyad. Hello, everybody. I'm so happy and it's a great pleasure to be among you and among the clinical engineers. Although my background, I'm a medical doctor and experienced in the health insurance and the health financing in my country, Egypt. Next, please. The next slide, please. The first, yes, this is my short biography. Whoever is interested to know more about my biography, he can refer to the presentation later on after the webinar. The first slide is about the 3 lessons learned from the COVID-19 crisis, which all the world is facing. The first lesson which is learned from this crisis is that we need to recall the statement of change is the only constant in life, in the world, in the universe. This statement is actually on the ground now. There is dramatic changes that occurs in everything around us, not only in the healthcare domain, but in the social, professional, political, economic, financial, and everything. Priorities are rearranged and we are still living but adapting. So the first lesson is how to adapt when facing this crisis, the COVID-19. The second one, that the COVID-19 crisis discloses the hidden potential of the distant and electronic learning, meeting, and the business-wise. The distance learning as well as the telehealth, and now it's quite tangible and dominated in the business of the healthcare market. The virtual meetings proved that we were losing many of our resources in the in-person, in the physical, in the face-to-face meetings before the crisis that can be more effectively and more efficiently run through the online meetings. Televisits and teleconsultations can replace many of the physical visits to the doctor office and clinics. And I think that after we are going to overcome this crisis, nothing will go back as it is before the crisis. The telemedicine, the teleconsultation, the telehealth is going to have a great place in the future. The third point is about the resilience of the health system. The resilience of the health system is of crucial importance. In the variation of the countries to respond to this COVID-19 epidemic or the pandemic depends mainly on the resilience of the health system, beside the very important point, which is the political support. In my country, there is quite redistribution of the resources toward the COVID-19 campaign because of the political support. I need to add something else here about the pandemic is the triggering factor that triggers all the country to innovate the products of the COVID-19 necessary equipment, starting from the simple face masks, the disinfectants, and up to the pulse oximeters, ventilators, and the CT machines. Next, please. Next, please. Yes. The second slide is about the challenges we are facing in the COVID-19 crisis. The first challenge which many of the countries, including mine, that is suffering from is the shortage of the healthcare workforce. And not only the healthcare workforce, but particularly the specialized physicians and nurses and pharmacists in the primary care functions, the public health, and the intensivists, whoever working in the intensive care. Also, there are shortage of the medical supplies, as the masks, the disinfectant, thermometers, pulse oximeters, ventilator, even the CT scans for the chest CT, which is now demanding all over the countries. There is shortage of the free access of the ICU bed in the public hospitals because they are all equipped at the peak period of the disease, all leaving the patients to face the financial hardship when seeking to be treated in the private hospitals. And so they are going to face the catastrophic health expenditure and even the impoverishing health spendings. Another related challenge is the shortage of the biomedical engineering, the qualified biomedical engineering to maintain the medical devices which are used in this management of such a crisis. The third point is about the resilience of the the third point is about the uncertainty of the line of the treatment of COVID-19. Every day, every few days, every week or 2 weeks, we are hearing about the new medicines and the new innovations for treatment of the COVID-19. And few days later, we find that there is uncertainty about the effect and the efficacy of those treatments. So it is one of the challenges, which is the uncertainty of the line of the treatment of the COVID-19. In the meantime, if any country, and as if, for example, my country, they propose the line of treatment. This line of treatment, although it is subjected to the uncertainty, there is shortage for the public people to receive such a treatment. The next one about the non-COVID-19 emergency cases. The people who are suffering of emergency cases not related to COVID-19. And the non-emergency cases outside the COVID-19, they do not find an appropriate place to receive their needed health care. This is a very important challenge. This will lead to increase of the out-of-pocket spending. That will elongate the waiting time and the waiting lists, and particularly for the elective non-emergency healthcare services. The last point is about the financial constraints. The financial constraints depend on the extent of the fiscal space in the government budgetary. How extent the fiscal space can cope with this great crisis. It is not a health crisis, an economic crisis as well. So the fiscal space, and particularly the fiscal space for health, is a main factor, that a main challenge that most of the countries are facing. And it depends upon the redistributive power of the resources in the country. That's in short what the main 3 or 4 main lessons and 3 or 4 main challenges. Thank you very much.
Thank you, Dr. Mohsen. Now we're going to have the presentation done by Tazeen Bukhari and by Daniel Fouaz, sharing their experience from Pakistan. Please.
Hello, everyone. Thank you, Dad, for the introduction. This is Tazeen Bukhari, and I'll be representing Pakistan along with my colleague, Mr. Daniel Fouaz. I would like to start my presentation with this. With health technology, innovation, quality, availability, regulation, and infection prevention control go side by side. And this is what our presentation is based on. Next slide, please. Next. Pakistan was one of the worst hit countries in the region, with a total of 263,000 cases, out of which now 204,000 have recovered, with a death toll of 5,500. We peaked around mid-June, and our first case was reported on 11th March 2020. We had designated 204 facilities with over 3,000 beds. Next slide, please. Like most of the countries, our challenges were similar, although we had designated 3,000 beds, but there were still hotspots in the country, especially in urban areas, and there was a shortage of HDO facilities, especially around mid-June. Most of the medical equipment in Pakistan is imported. Hence, there was a shortage of PPE, ventilators, pulse oximeters, oxygen cylinders, just to name a few. This created panic among the population, and the prices went ballistic. Pakistan already lacks a clinical engineering structure in most hospitals. This pandemic created a burden on a scarce resource. Lastly, we do not have a centralized, conclusive facility-wise inventory list. Hence, it was nearly impossible to collect data on the availability of various equipment throughout the health facilities in the country. Next slide. Having highlighted all the challenges, this pandemic was a blessing in disguise. It made the government and the private sector focus more on health technologies. There was a boost for the local manufacturing. Textile industry shifted to producing and exporting PPEs. Engineers started designing ventilators, resuscitators, and testing kits, and are now in the process of clinical trials and eventually getting them registered with the Drug Regulatory Authority of Pakistan. Private organization also stepped in, trained personnel, and prepared various non-functioning equipment in the country. Lastly, now with the help of WHO, we're conducting a very conclusive biomedical survey throughout the country, and we're hopeful that this will identify gaps beyond COVID-19 and corrective measures can be taken in terms of equipment and HR to avoid such things. Now, I will hand over to my colleague, Mr. Daniel Foz, who will tell you about Chowk Memorial Hospital and how they dealt with the pandemic.
Thank you, Kazim, and all of you, to give us such a wonderful opportunity to share our experience and knowledge during this pandemic. Next slide, please. I am Daniel, working as a senior biomedical engineer at Shaukat Khanum Memorial Cancer Hospital since more than 12 years. Shaukat Khanum Memorial Cancer Hospital is a state-of-the-art tertiary care cancer hospital, which is providing free treatment of around 70% of poor case cancer patients. Shaukat Khanum is a specialized and unique cancer hospital of 195 beds. However, in the wake of current situation, we were taking a number of steps to fight against COVID by the capacity enhancements to deal with COVID patients with 8-bedded triage and assessment beds, increase of 35 ICUs and 25 inpatient COVID beds. Average of 250 patients visited and screened on a daily basis. For the staff and patient safety, we have divided a safe and affected zone inside the hospital to help staff and patients as well. Next slide, please. Next, please. We are facing a number of challenges during this situation, but particularly as a clinical engineer, we are facing a big challenge to maintain a smooth supply chain of medical devices and their spare parts, and in somehow quality was also compromised. To ensure provision of core services of medical equipment, this is again a big challenge to maintain quality services and response with the limited staff. Ensuring maintenance of our standard response time, which is our main goal to respond to complaint of medical equipment within 15 minutes, and it is badly affected because of the PPEs that have been enforced by the management. Next slide, please. As we have never prepared before the situation like this, a few of the important, please go back. Please back. Previous slide. Okay, as we never prepared before the situation like this, a few and important lessons we learned are. Next slide, please. Next slide, lessons we learned. Capability and testing of oxygen supplies. Availability of oxygen at various flow rates, maintaining pressure at all times. This was taking a couple of practice and testings to maintain pressure on each outlet with maximum flow. This was also given a lesson that how much capacity we have in our oxygen tanks and all cylinders and the required backup. And by this, we concluded that on alternate days of oxygen tanks must be filling of the oxygen tanks must be required. Management of resources is another big lesson. Due to the current COVID crisis, there has been a shortage of ventilators worldwide as our healthcare providers are struggling to cope with the high influx of patients. To develop a resuscitation device or a ventilation system with basic controls of volume, breaths per minute, and inspiratory-expiratory ratio. And MBUVAC is an easily available device in every hospital and the commonly used for the manual resuscitation. We have developed, the picture shown in the slide, we have developed a prototype that supports volume controlled mode of ventilation. Target is our and monitored closely during our testing and measuring tools. Due to using easily available local parts, our design included the compressor through a program driver. Atmospheric air is used by the ventilation and no external cylinder is attached. External oxygen can be delivered to the patient using the flow meters to control the patient oxygen saturation. The main control parameters are the volume, breath per minute, and the inspiratory-expiratory ratio. The second lesson is limited to other cancer treatment services because of the unavailability of equipment and its backup. And this is also for our big lessons to make available backups of medical equipments to handle the situation like this. With the reduced number of staff because of the social distancing, and our staff was also COVID affected, So this is our another big lessons to maintain core services over. Finally, I would like to say a lot of challenges we faced and lessons we learned by this pandemic. And at least this will help us to improve and prepare ourselves in a better way to handle the situation efficiently and more effectively. Thank you so much.
Thank you very much. Thank you. I was trying to go through the buttons a little bit. It's not an easy job. I just apologize from the panelists. Again, Dr. Mohsen, thank you very much for sharing with us the readiness for change, teleconsultation, and the resilience for health system. Thank you, Tazeen and Danielle, for sharing the experience and the shortages and the safety items and the lesson learned and the maintenance and the parts. Thank you very much. Now we're going to have the floor for Dr. Yassin Abdul Samad. The floor is yours, but please, everybody, please share the Q&A. At the end, we're going to read the questions and answer them all, hopefully. Please use the Q&A button at the bottom of the Zoom window. Use the Q&A, please. Thank you very much. Dr. Yassin, the floor is yours.
Thank you, Dr. Riyad. Good afternoon, everybody. I'd like to talk about the key health technology learnings and the challenges during the COVID-19 crisis in the EMRO region. Next slide, please. Actually, for me, the first learned lesson from the COVID-19 crisis in the EMRO region is that the technology could help. And actually, I'd like to share with you a success story related to this lesson from Saudi Arabia. And for me also, the second learned lesson from the COVID-19 is that the clinical engineers' roles during the COVID-19 are noticed and highly appreciated around the world. Next slide, please. Linked to the first lesson, which is a technology could help, I'd like first of all to introduce to you the cochlear implantation system, which is a popular surgery to treat the individuals or the patients with severe to profound sensorineural hearing loss. Actually, the CI system consists of two parts. The first part is the internal device, which is implanted in a surgical procedure, and the second part is the external device, which is also called the audio processor. And this audio processor picks the sounds from the environmental area to the patients and process it before sending the processed sound to the internal device, which start to stimulate the auditory nerve so that the patient can start hearing. Actually, the CI system or the CI patients have to visit their clinics on a monthly basis after the surgery for at least 1 year to keep following up and programming their devices. This continuous programming sessions is required, and it is mandatory to keep and readjust and improve the hearing and speech levels for the patients. Next, please. The programming sessions generally are done by either audiologists or trained clinical engineers. Actually, in Saudi Arabia, the impact of the COVID-19 crisis has been far-reaching on the CI patients, as those patients are facing many problems and difficulties to visit their clinics in Riyadh for follow-up and programming their audio processor. So, and if this is the case, many patients will be kept with insufficient levels of hearing, and the other patients will not have any chance to activate their audio processors. Next, please. So our clinical engineers actually came with an interesting idea to do this programming session and follow-up sessions remotely. They just use free and open access software to give the audiologist or the clinical engineer full control on a remote computer placed beside the patient in their home city so that they can do the programming session and follow-up sessions remotely. And now all patients are having their programming sessions remotely. Next, please. The second lesson is that the clinical engineer or the silent heroes during the COVID-19 pandemic are noticed and highly appreciated. Actually, the Global Clinical Engineering Journal dedicated its front page cover to recognize all activities and all support of clinical engineer professionals during the COVID-19. Next, please. And here I have summarized some of the critical rules which have been written in the literature about the critical rules of the clinical engineers during the COVID-19. Actually, the support of clinical engineers has different forms. They support in designing and manufacturing the respiratory equipment. They also support in providing personal protective equipment. Moreover, our clinical and biomedical engineer give a great support in building temporary hospitals. They also served as a vital links in coordinating the supply chain of the life-saving medical technology. Moreover, our clinical engineer also support in solving the problem from the gas pipeline to the manufacturer's delay issues. Next, please. But coming to the challenges, I actually have two challenges here to mention. The first one is that despite the great efforts of the clinical and biomedical engineering during the COVID-19 pandemic, I think we still have rare publications on our contribution to the COVID-19 problem. And I think we have to do more efforts toward having dynamic plans for the disaster situation. Next, please. Here is an example for the rare publications of our clinical engineering activities during the COVID-19. The first article reported the Italian clinical engineer experience during the COVID-19. They covered three aspects, as actually the machine availability and the organizational issues and the acquisition problems of the devices. And here we have a second example for the publications related to the clinical engineering during the COVID-19. And this article reported the role of biomedical engineering during the COVID-19 pandemic, and it's published in the Natural and Applied Science Journal. And this was a review article to review all the artificial intelligence application during the pandemic. Actually, you will find more resources from the IFMPE and the WHO in this presentation when we share it with you. Next, please. However, and if you just go to the ResearchGate website, which is a popular platform for the researchers worldwide, and you just use the keywords such as clinical engineering or biomedical engineering or medical equipment management activities, you will actually, once you open this website, you will find more than 65,000 publications related to the COVID-19. However, we have rare publications related to the medical imaging. I think they are 500 publications, and we have like 300 publications related to the machine learning and deep learning. And unfortunately, we don't have any sufficient number of publications reported and related to the clinical and biomedical engineering activities during the COVID-19. Next, please. So I think that more efforts should be done.
Less than 1 minute, please. Thank you, Yassine.
Okay. More efforts should be done toward having more dynamic plans for the disaster situation. I think we should be more ready for any upcoming disaster or emergency situations. And I think we have to give more support to revisit the relevant guidelines to increase the bed availability during any disaster situation. And finally, we should propose more dynamic models for the healthcare facility design in general and for the medical equipment listing in particular. Thank you.
Thank you very much. Thank you, Dr. Yassine. Thank you for the success story, for the remotely programming solutions, for the appreciations for the clinical engineers and the researchers and the information on the researches done by clinical engineers. Now we're going to listen to the experiences presented by Muhammad Yunus. Please, Muhammad, the floor is yours.
Yeah, thank you, Riyad. I would like to discuss the challenges and the lessons learned by the hospitals in the UAE during this COVID crisis. The first, there are several challenges, but the most significant was the inability of the hospital utility services to cope with the increased demand arising with the need to create more isolation rooms, to have more ventilators. That means the medical gas supplies were taxed to the hilt, and then we had to make they had to make supplementary arrangements through cylinder banks, manifolds, and fortunately the supplies were available to cope with this demand. The HVAC systems were also taxed. The onset of summer made the matters worse. We had plans to incorporate recirculation systems to create isolation rooms so that we don't lose the cold air. But because of regulatory requirements, this could not be achieved. We had to exhaust all the air from the room. So we had to install additional split units to cope with this. The third utility, which was significantly taxed, was the sterilization department, where there was, because of supply chain disruptions, there was a lot of demand to reuse material, and it had to be sterilized. So the UVC disinfecting systems were helpful to a certain extent, though there was much to be desired end of the day in this system. Can I have the next one, please? Can I have the next slide? Yeah. So the second challenge, can we go back on number 2? Yeah, thank you. The second challenge was, how do we cope with the new equipment that were coming in? Like, there was a lot of procurement happening, and not all the standard practices to assess and have a uniform models in respective departments or in particular ICUs were bypassed. So we ended up having a lot of variety of equipment in one place, where clinical users have to learn functional requirements, operating systems, alarms, and accessories for each of these equipment, and the staff shortages were aggravating the system. So one idea was to have quick use guides tagged to each of these equipment, but those posed additional infection risk. So we ended up having biomeds in each of these ICUs to support the clinical staff to intervene when they were having difficulty in using the systems. Number 3, please. Next slide. Yeah, the third challenge for biomedical engineers was to reschedule the planned maintenance activities, because the sudden demand for the crisis, several maintenance activities had to be deferred, and several equipment had to undergo a new risk profiling so that the schedule could be valid. And added to this, there was a lot of work arising from new equipment coming in, supporting procurement, then doing the acceptance testing, training staff. So many of the standard procedures had to be suspended, and emergency procedures put in place, where support staff have to be roped in to cope with the additional demand. Also, we had to request suppliers to reschedule supplies, make deliveries off hours and during weekends, to do maintenance, to do acceptance testing on the test equipment brought in by the suppliers themselves. So there was a bit of compromise on the standard procedures here. Can we have the next slide, please? There are several lessons learned, but I'll try to capture the most significant ones here. The 3, first of all, is that biomeds are the equipment health technology managers. We have to be cognizant of the fact and align ourselves with the disaster preparedness policies of the hospital when we are selecting equipment. A significant amount of these equipment should be able to work independently of the utilities as they work in remote areas, whether it comes to longer battery lives, or having compressed air systems on board, or having oxygen concentrators on board. So this will reduce the dependency on the utility systems, and the hospital utility system is not taxed during such crisis situations. Can we have the next slide?
Please, Muhammad?
Yeah.
Yes, thank you.
Can I have the next slide, please?
Sure.
Yeah, and I will just skip this because this contains the facility part of it. Can we go to the last slide just to save time? Yeah, most significant for clinical engineers is to relook at how equipment are designed and used, because most manufacturers focus on differentiating their products and end up having very different products for the same function. And clinical users and biomeds always struggle with the training and getting used to the new system every time a new piece of equipment comes in. So the industry could learn from other industries like consumer electronics, mobile computing, to standardize on the user interface and user experience so that the clinical learning curve is shortened. And this is where biomeds can and clinical engineers can contribute a lot. Thank you. I hope I've made it in the requisite time.
Thank you very much. Thank you.
Thank you.
Thanks. Now we're going to have a presentation from Bassam Tabshouri. Mohammed, thank you for the information on the facility requirements and isolation rooms. And again, all questions and answers are till the end. Okay. Now the floor is yours, Bassam.
Thank you, Riyad. So I will be talking about the challenges and learnings from the COVID-19 crisis in EMRO, basically the Lebanese experience. Next, please. My presentation will focus on 3 areas. I'll give a quick background about what's called HTMA, Healthcare Technology Management Advancement, the challenges and learnings within our institution, the American University of Beirut Medical Center, and the challenges and the learnings we took as the Lebanese Healthcare Management Association. Next, please. The HTMA is a committee or a society within the Lebanese Healthcare Management Association, which was founded in 2002. It is a non-governmental, non-profit association, not affiliated and not involved in any political party or activity. It can open branches in Lebanon and abroad. HTMA started in 2016 and the first activity was in 2017. Next, please. The goals of LHMA are to connect professionals to lead initiatives for advancing population health, healthcare management and technology innovation through education, collaborations, consultations, conferences, research, publications, and focus group. Next, please. So the vision of the HTMA is to lead innovative healthcare technology management, assessment, advancement of solutions and initiatives for safe quality healthcare, education, and research through the development of professionals, standards, systems, and technologies in Lebanon, the MENA region, and globally. Next, please. So we'll talk now about our experience in our medical center. This is a picture showing 4 buildings from our center. There are 2 more, and we'll be focusing on building 56 on the left side. Next, please. This building, we transformed it into a COVID center, and we had a lot of challenges because the lowest floor is for St. Jude Cancer Center, and the other floors are occupied. Next, please. So we needed to set up a COVID center in 10 days and to relocate the other departments to other buildings. We needed high coordination of different teams, plant engineering, clinical engineering, IT, etc. We also needed to avail equipment for the COVID center and to train the staff on working in a COVID environment and handling COVID patients. We had a role also in training on simulation sessions of how to handle COVID patients and equipment under that environment. Next, please. One more challenge is that the staff was asked by the administration to work from home as much as possible and to work on a shift basis. So this reduced the number of staff available on site. We needed to revamp some of the built-in house ventilators for emergency use. And due to the HIS EPIC system that we acquired 1 year ago, we needed to look into the workflows and platforms for COVID-19 patients. We needed to develop them, as well as for telemedicine consultations. We needed the team morale and safety have been a very big challenge in the midst of layoffs in our institution and the COVID-19. Last week, we had like 850 persons laid off from our medical center. Next, please. Now, as our experience as an association, you are seeing here some pictures of meetings held within the Ministry of Industry to help in developing locally ventilators. Next, please. And these are other meetings in the Prime Minister local for the same purpose. Next, please. So our group worked on online meetings to set Lebanese standards for oxygen systems, masks, ventilators, CPAP, BiPAP, pulse oximetry. We are advising and supporting the local industry, 3 different plants, and we're giving advice and support to our colleagues and other institutions. Next, please. What are the lessons learned? Like Dr. Mohsen mentioned, we need to monitor daily more than once what is going on internationally and locally and adjust our plans and safety measures. And thanks for IFMBE for the very valuable resources we're getting. Number 2, we need to get out of the box to innovate to cover the shortage of equipment and spare parts and staff. We need to share our information, knowledge, expertise within and outside the institution, and to keep a positive attitude and the resilience. Next, please. Really, the issue in our region is way beyond the issue of COVID. We have a lot of challenges in our country and in the region due to instability and lack of human resources and the financial problems. All of these are a call for us to put extra innovative efforts together, and with IFMBE and our international friends, we can make a difference. Thank you.
Thank you, Bassam, for the wonderful presentation. Thank you for sharing the HTMA work, the work that HTMA is offering for Lebanon and for the area. It's important to know that the changes in the facilities are so essential to face COVID, the training, and we should be ready to work from home. Thank you very much for your experience. Now, we're going to have the presentation followed by Hugo, who's going to share his expertise in working in Yemen with Médecins Sans Frontières. The floor is yours, Hugo.
Hello, everyone. Thank you for letting me presenting a bit our experience in Yemen. First of all, I want everyone to know that I was unfortunately not able to be in Yemen due to the border closure and things like that, but I've been heavily involved in supporting technically the intervention there. So that's why on behalf of the team which is on the ground, I can do this presentation. So first, Doctors Without Borders is not only a medical organization, but we also like testimony our interventions and things like that. So between after the first cases identified in Yemen and today, MSF has published on his website 5 different articles regarding the COVID situation in Yemen. Can we have the next animation, please? So from the first date in April, the 10th of April, we have published article calling for the authorities of Yemen to urgently allow the entrance of supplies and humanitarian staff to the country in order to facilitate a response to the disease. I will let you go to the website and read the different articles, but you will be able to see that further we go in the timeline and more scary the article are about the situation, leading to the latest article in July, 9th of July, where we witness a new COVID facilities that we just opened, and that was half occupied because the population was scared that the hospital could actually like bring them to get the disease. So there were complete like misinformation and rumors, which kept people away from the hospital. And I think that that's one of the most one of the biggest lessons learned for MSF in terms of response of this pandemic is that actually you can put any technology on the ground, but if you don't have a strong community approach and communication and transparency about the disease and things like that, you can really harm the population rather than help them. Next slide, please. Next. Yeah. So now more focusing on the biomedical challenge. One of the biggest challenge was obviously the oxygen access. Some of my colleagues have published a really interesting 3.5 minutes length video regarding dealing with oxygen supply and challenges. Just allow me to give you the highlights of this video, but you can access them on YouTube. Next animation, please. So we opened a COVID center of 40 beds in Aden, in the south of Yemen. Out of these 40 beds, about 28 were for severe cases and 12 for intensive care and critical cases. This ended up using 250 bottles of oxygen per day. This is an enormous amount. Regarding financial cost, obviously, which brought 80,000 euros per month, but also a huge amount of logistics and resources for the transport of the bottle, the change of the bottles and things like that. So next animation, please. Obviously, the next the solution that have been brought are the oxygen concentrators, which we faced a drastic shortage of these oxygen concentrators, and increase of the cost because of the rarity of the oxygen concentrators. Next, please. The second solution was to bring oxygen plants, which is another supply and technical challenge because of the delay to have such equipment brought in the country, and also the time of implementation and things like that. We had the experience of having one oxygen plant installed when the planning was validated. It was 70 COVID patients, and once it was installed, only one patient left with COVID. So that's also one of the risks. But so it's always a matter of balancing the response, the availability, the supply availability, the time of implementation of the technical solutions. And regarding now, one of the lesson learned is that there were no, at any point, whether it would be in Yemen, Bangladesh, other parts of the world where we intervened, there were no one solution fits all. It was always evaluation and assessment of the context of the situation, and trying to predict the future as much as possible, which was almost impossible. So strong communication and links with epidemiologists and things like that. Next slide, please. So here you have map of the Yemen, and as you can see, we are intervening.
In 1 minute, please, Hugo. Thank you.
Sure. We are intervening in quite a few places. Let's animation, please. Mostly in the east. So this is all different MSF intervention mixed. The main points were regarding the biomedical intervention was the increase of our HR capacity on the ground, with hiring one biomedical specialist in Hassan for the support on the ground, and then focused support remotely, which I was. We opened a COVID hospital, as I say, in the south, but also in the capital. And one of the main focus for MSF was to keep regular activities, medical activities. That was one of the main focus, but in some cases, depending on how the COVID cases increased in the area, we had to open what we call CTC, so for COVID treatment center. We also are now working on repairing an X-ray machine and on increasing the oxygen production system in different projects, with 30 oxygen generators, 1 oxygen plant, and repairing 1 oxygen plant in collaboration with RCRC. Yep, next slide, please. Yeah, thank you. So one lesson learned is that we could not work at all alone in all of that, and everyone is needed to face this COVID. So it's important to share messages and to share supports. Thank you very much.
Thank you, Hugo. Thank you for sharing your experience. And of course, communication is very important. The oxygen access and oxygen concentrator have been always mentioned by WHO, IFMB, and definitely you and everybody who works on the ground, that oxygen supply is so essential. Thank you. And definitely there is no one solution that fits it all. Thank you for all the panelists. And a note, a message for all the attendees to share their questions and answers in the Q&A button. We still have 10 minutes, and the panelists have around 1 or 2 minutes to answer the questions. Now for Dr. Mohsen, do you think in our area, our quality and safety and accreditation, did it make it us readier to face COVID, or do you think we still need to make some legislations and improvements in our accreditation or quality or safety in the hospitals where we work? Your expertise in this area is so essential. Would you like to answer this question, please?
Yes, please. Yes. Thank you for this very important questions. Actually, in my country, it was not already prepared to deal with the COVID-19. But because of the health system, starting the reform of the health system few years ago, this helped us so much. But this was on the expense, as I mentioned in my challenges, on the emergency non-COVID cases and the non-emergency cases. We dedicated the vast majority of the public facilities to be for COVID-19 patients. So we are facing a challenge now. How we are going to manage the patients who are not diseased by COVID-19 and they have another diseases. Another point about the safety and the quality, as I said, that we are on the road to the accreditation. And few years ago, we established a centralized accreditation or authority, which belongs directly to the President of Egypt. And this mentioned and set a set of standards, and we are preparing our hospitals to fit and to comply with those standards. It was not so much difficult, to deal with the COVID-19, but the difficulty actually is the other patients, not the COVID-19. We are ready with the personal protective barriers. We are ready with the ventilators. We are ready with the disinfectants and the masks, but there are shortage for the public. It is not present elsewhere except in the public hospitals. For that reason, we dealt with fortunately enough, now we passed the peak. Now we are in the decline phase in Egypt. But whoever knows that, are we going to face another peak or not? Nobody knows this. The uncertainty is the main title of the condition of the COVID-19. So we faced several challenges. One of the good points that now we are manufacturing local ventilators. The ventilators was not locally manufactured in Egypt before the COVID-19. Now we are, this is one, yes, this is one of the very good and strong points of the COVID-19.
Absolutely. Thank you, Dr. Mohsen. The same as Bassam also shared that HDMA helped a lot in the area and putting the minimum specifications and safety and testing for the rapidly manufactured ventilators, which helped a lot the patients during this area. It was a wonderful presentation, wonderful set of webinars, and a huge amount of experience shared to everybody. A final point for any of the panelists before we close, because we are running perfectly on time and we need to finish in 1 minute. Any notes from the panelists? Any final notes from anyone of the panelists, please? Any notes? Thank you very much. Thank you very much for the wonderful webinar, and hopefully we're gonna meet again soon. Hopefully in person, no one knows, but most probably on webinars. Thank you very much. And I hope everybody has learned from this webinar and shared the experience. Thank you.
Sure. Thank you very much.
Thank you, Tom. Thank you, Kelly Roy.
Thank you.
Thank you very much.